Good evening, everyone, and thank you very much for your time tonight. My name is Khalid Shkir, and I am working as an international program manager with the American Heart Association MENA region. Today, we'll present to you the RQI and get with the guideline journey and best practices by international and regional distinguished speaker. If you have any question, please, during the presentation, please type it into the Q&A box. We'll bring them up during the Q&A session at the end of the webinar. And now, without further ado, we will turn the time to our speakers. But before that, I'll give the mic to my colleague, Mr. Rami, to introduce himself and the speakers as well.
Thank you, Khalid. Good evening, everyone. This is Rami Khattar. I am the General Manager for the AHA MENA office. So it's a pleasure to be with you today. And let me introduce our distinguished speaker for today, starting by Mr. Josh Onya. So he's the RQI International Program Director with the RQI Partners, and he's serving as the program director for the RQI International. Josh drives the innovations of the resuscitation equality improvement digital programs globally, and he has led the transformation of programs in multiple parts of the world, increasing healthcare provider competence and confidence in high-quality CPR. Is an RQI data and compliance expert as well, and key contributor to the development of the RQI analytic application. And he is a paramedic for over 25 years and is committed to finding solutions globally to help save more life from sudden cardiac arrest through digital learning solution designed to drive mastery of resuscitation skills. So thank you for being with us, Josh, today. As well, Mr. Marius Oliver. So he is the manager of the resuscitation and ambulance services at American Hospital Dubai. Marius is a South African trained paramedic with a special interest in the resuscitation and aviation medicine. He has a passion for resuscitation and resuscitation training and is an avid advocate for high quality CPR. He has a very special interest in the RQI Definitely program and support the development and the growth of the program in the region. And he has been an AHA instructor since 2003. As well, he is an AHA regional faculty and has been involved in the development of AHA instructors, AHA centers in the region and abroad. And he holds a master in business administration. Welcome, Marius. Dr. Hatem Al-Tahir, he is a consultant cardiac anesthesiologist, and he is an AHA regional faculty at Saudi Battain Cardiac Center, Dammam, Saudi Arabia. And he served as an AHA training center coordinator since long time. As well, Dr. Hatem, he is a very active AHA regional faculty and has been involved in the development of AHA instructors, AHA centers, and the training of TCF in the region. And we are pleased to have him with us today as well. Welcome, Dr. Hatem. Thank you, Khalid. So we'll start with our first speaker with Mr. Josh.
Thank you, Rami and Khalid, for the opportunity to be here today. And the chance to talk about RQI as a digital resuscitation education. I appreciate the chance to share the stage with these great speakers from the region. So I'm going to talk a little bit about who RQI Partners is, and I'll share a little bit about, briefly review some of the science and guidelines that RQI is built upon. We'll talk about the programs, I'll give a brief description, and then also explain how we measure to improve and the importance of that. Currently, RQI is helping save lives globally. RQI Partners is a partnership between the American Heart Association and Laerdal Medical. We're focused on helping save more lives by delivering innovative solutions that support our vision to eliminate the preventable and unexpected cardiac arrest deaths. Our programs, they're available around the world, and we partner with organizations like the British Heart Foundation, like Irish Heart Foundation, Swedish Resuscitation Council. And currently we have RQI programs in 7 different languages, in over 25 countries and over 1,500 hospitals and organizations around the world. We'll talk about the science and guidelines first. First, we want to build RQI based off of the science that's extremely clear. We follow, it's extremely clear that high quality CPR is the absolute single greatest determinant of cardiac arrest patient outcome. And we know that within about 3 to 6 months from time of assessment, skills tend to begin to decay. And we can see this in this visualization here. If you look at the blue waves on the screen, the peak of the blue waves is traditional training when we train, whether it's once a year or it would be once every 2 years, depending on how you currently train. And so basically your skills they're very proficient at the time of assessment, and then they begin to decline over the course of very rapidly from the time that you're assessed, especially if you don't use them or reinforce them. And with RQI, with the RQI program that we're talking about, we want to maintain the proficiency of high quality CPR skills. And we do that with refresher training that's incorporated every 3 months. So on a quarterly basis, 4 times a year, we reinforce the skills of high quality CPR through practicing compressions and ventilations and verifying competence of skill, so that we can work toward preventing poor quality CPR as a potential reason for poor outcomes. In 2020, the guidelines reinforced what the science is actually showing us. So we need to incorporate training interventions that include the deliberate practice and mastery learning. We need to incorporate the addition of booster training. We should use a spaced learning approach. And when we train, we need to be training with feedback devices so we can get objective feedback on learned performance. It's these training interventions that are going to improve skill acquisition and skill retention, ultimately improving the care being provided to patients. So this way we can ensure that every patient, every single time, is receiving the best possible cardiopulmonary resuscitation from the providers who demonstrate their competence and establish a level of confidence in their CPR skills. My friend Marius is going to be talking more about this in a few minutes. I also want to point out learningrqi.com. This is a website that is available to anyone, and I encourage folks to take a look at it. This important website is a powerful online resource, and it demonstrates all of the science which RQI is built upon. And so you can look at it and subscribe and receive alerts. Every single time there's new peer-reviewed literature that is published, reinforcing the science behind any of our programs. So now we'll take a quick look at our programs, as well as Marius will talk about them as well. So first, we'll talk about the RQI program. And RQI, our programs, they provide a high reliability, they're delivered on a high reliability platform and designed for mastery learning. And they're the approach we use is what we refer to as a low dose, high frequency approach for quality improvement. So and followed by measuring the competence of our provider skills. In the beginning, when learners are enrolled in RQI Provider or BLS, they begin in one of 2 pathways through a prep assignment, which would be for a novice learner that needs to establish the foundation of knowledge prior to beginning the RQI program. Maybe a new learner that maybe has not ever had BLS before, or ACLS or PALS. Or for your experienced learner, we have the ability for them to start an entry course, which essentially assesses the learner's knowledge of the core learning objectives for BLS, ACLS, or PALS. Upon completion, they'll receive their verified e-credential, and then on the first day of the next calendar quarter, the learner would start their perpetual curriculum where they'll demonstrate their skills of high quality CPR, and then they'll also reinforce one of the BLS, ACLS, or PALS algorithms through what we call a cognitive assessment activity. The e-learning and the quarterly cognitive portion of the program, it's completed through e-learning, and it can be assessed on most devices, on a smartphone or a tablet or any computer, anywhere the learner can access their learning, and which provides a lot of flexibility and transfers the accountability to the learner. So learners will complete the cognitive assessments through which will be an introduction to a case, and then they'll answer questions or probes while they'll receive feedback throughout the course, and then as well as being debriefed. When they do the prep course, they will experience a truly adaptive experience where the course will adjust based on the learner's level of knowledge. So if the learner can self-assess in the beginning of the course, and if they're an expert or a beginner, they will be served up, an expert would be asked a question related to the terminal learning objectives. And then once they're asked the question, as long as they know the content, there's no need for them to do take additional time. So they'll ask, unless they get a question incorrect, then they will be given just the content that they need. The skill sessions are all done at the RQI simulation station, and when organizations participate in the RQI program, they're provided with a simulation station with an adult mannequin and an infant mannequin, and each quarterly session includes adult child compressions and ventilations, and then infant compressions and ventilations, which are the core foundation of high quality CPR. And so, and you'll hear more details about the feedback from my colleagues here in a few minutes as well. So when we talk about measuring, we want to make sure that we measure. We want to measure to improve our outcomes, and there's no way to know unless we are measuring. So we measure through things like Get With The Guidelines, but we also want to make sure that we're measuring our learning. So in order to do that, we have analytics incorporated into our programs. And so RQI Analytics is designed to help you understand the current state of your RQI program. And we do that by looking at historical data and trends around focus areas, and allows you, and based on the findings, it allows you to focus on where improvement might be needed. So this part of the program allows you to really gain valuable performance insight in order to optimize training efforts, enhance your continuous quality improvement measures, and ultimately so that we can save more lives. All organizations that participate in RQI gain access to the Get With The Guidelines resuscitation module at no cost as well. Within RQI Analytics, we're really focused on presenting the data and the visualizations of learner performance. It's not a live dashboard, but it shows historical information trended over time, allowing for drilling down to the organization or department level, job titles, or even down to the individual learner. So this overview page provides defaults and shows the previous quarter's compliance and skills performance, and then shows that against the previous quarter. When we look at compliance, we have the ability to look at exactly how many assignments might be made, how many learners were compliant, how many learners were not, and we get an opportunity to understand if they were not compliant due to just not making it to the RQI station, or they didn't do their cognitive activities, or a combination of both. We also have the ability to take a look at the compliance trended over time, and we can see the compliance rates for groups of learners that have been in the program more or less than 1 year. Historically, the learners, as they become more comfortable with RQI, their compliance tends to increase. And then on the right, we see a visualization of completions, distribution of completions throughout the quarter. And we can see when those busy times are, and human nature tends to find us waiting till the last minute, where we have often have an increase in activity at the RQI simulation station, but we can monitor that quarter after quarter. As far as skills go, we have the opportunity to look at the detailed metric performance when we compare the core skills of RQI. In this example, we're looking at, and I apologize, it's in German, but we're looking at the skill of chest compressions, and the chest compression, all of the metrics associated with viewing chest compressions. So looking at compression depth, recoil, rate, hand placement, and chest compression fraction. And then we can also see the number of attempts the learner has, what their first passing score was, and the range of their scores. And then at drilling down deeper into the individual level, we can actually see the trends and the details related to each and every single attempt, the date, the time, and what the details were for that attempt. And that's really a quick overview that I'm happy to share. And please continue to ask your questions into the chat, and I'll pass it back to Rami and Khaled. Thank you.
Thank you so much.
Josh. Go ahead, Khaled.
Thank you.
Go ahead.
Appreciate your informative information and presentation. Appreciated. Now moving to Mr. Marius, please.
So good evening all, and thank you for taking the time to attend tonight's RQI session. This is probably one of my favorite topics, and it's the RQI system. So the American Hospital Dubai started its RQI journey on December 15th, 2016, when we met with the AHA leadership at our hospital. We received approval from our senior leadership to start with the RQI project, and received our first RQI stations in March 2017. Our actual first staff members who started working on the RQI platform was on April 4th, 2017, and we never looked back. Previously, we were a very traditional model, starting with standard AHA classroom sessions since 2008, and later a combination of classroom and hardcode sessions. So I need to ask the question, how many of you participate in a sport? Why do we practice 2 to 3 times a week when doing a sport? But as healthcare professionals, we find it acceptable to practice our CPR skills once every 2 years during a CPR course. The old saying that practice makes perfect is no less true in resuscitation quality improvement than in any other human activity. The more often resuscitation knowledge and skills are used and practiced, the better the performance, which will lead to better patient outcomes. So what is the problem? We know that there's about 500,000 cardiac arrests annually in the United States. Out of hospital to neurologically intact survival is standing at about 11.4%. Whereas in-hospital survival rates is standing at about 23.8%. This means only about a quarter of patients survive in hospital cardiac arrest. Let me repeat that. That's 1 out of 4 patients will survive in hospital cardiac arrest with good neurological outcomes. This is such a significant number. We know that poor quality CPR is a preventable harm and that the 2-year retraining cycles are not optimal, and that more training in BLS, ACLS, and PALS may be helpful for providers who are likely to encounter a cardiac arrest. There is also substantial evidence to suggest that mastery learning is the key to skill retention and the prevention of rapid decay in skills and knowledge after simulation-based learning. The goal of mastery learning is to have learners achieve the highest standard for all education outcomes instead of simply meeting the minimum standard. So what is our old training strategy? Students attended a standard BLS, ACLS, or PALS course every 2 years, and the certification was issued based on the demonstrated performance at the time of the course. We know that skills degradation is steep in as little as 3 to 6 months, as Josh has mentioned. From a standard course, skill decay of up to 50% can be seen. And this is what we see. And again, Josh has shared something similar to you earlier. People completed training and they are basically at the top of the curve. And then as time progresses through the 2-year cycle, they end at the bottom of the graph. And this cycle continues as they renew their certification. So do you want a healthcare provider taking care of a friend or a family member that is performing at the bottom of the graph or at the top? High quality CPR is the single greatest determinant for survival from cardiac arrest and is the foundation for which all other therapies should be built on. And that was from the 2013 AHA consensus statement. A study by Niles et al. Also concluded that healthcare providers often do not meet guidelines on chest compression fraction, chest compression rates, and chest compression depth targets, and the compliance is poor. So what is RQI? RQI for us is a maintenance of competency solution. It helps hospitals and healthcare providers maintain their competency and achieve better patient outcomes through regular, low-dose, high-frequency training. At the American Hospital Dubai, we have RQI stations strategically located throughout our hospital, which is available 24 hours a day, that helps to minimize loss of productivity. So professionals can access the station anytime when they are ready. The skill sessions that the team does happens every calendar quarter, and they typically take less than 10 minutes. The system provides us both visual and audio feedback as they practice. Every quarter, there's also a cognitive that the team does or an online component and they need to complete. On successful completion of both the online and the practical, the providers will receive a new AHA e-card, which will be extended by 3 months. Another benefit is that providers are provided with expedited AHA science updates as AHA releases them. And I think this is very important. RQI is the first to receive these updates. As an example, we attended the AHA 2020 updates at night on October 21st, 2020. And the next morning, on October 22nd at 8, my team started with the new 2020 AHA guidelines during their RQI training. So our team was the first to start with the new guidelines, as other 2020 materials still had to be ordered from the suppliers. The core skills that are practices at our station is adult and child compressions, adult and child ventilations, infant compressions, and infant ventilations. Immediately, once a student has performed a practice attestation, it will provide an overview of the activity. If you want to have more information, you can easily click on the video tips icon. Here you will see a short video to provide you with a tip or tips to improve your CPR skills. Here, I achieved 100% during the chest compression skills assessment. I can click on the analyze result to get even more information. Here we can see that my initial compressions, which is highlighted in red, was too deep. I pushed down more than 2.4 inches, but I self-corrected during the practice session, and that's why I achieved a score of 100%. For every skills activity that we practice on the RQI station, the same analysis and tips are available. RQI is definitely an evolution in the quality of resuscitation training. By incorporating the components of mastery learning in our program, participants increase confidence, competence, and willingness to respond in a cardiac arrest event. Another important part in our organization is conducting regular mock or skill drills with dynamic team training. So we find this as an essential component as part of the RQI success of driving a culture of excellence. Students will develop mastery of skills on the RQI simulation stations, but the mock codes are strongly encouraged to develop team dynamics and good communication skills. At the American Hospital, we have skill drills monthly in each department as to ensure a culture of resuscitation excellence. With compliance of high frequency, low dose delivery of RQI content, the RQI provider will maintain and validate life-saving skills regularly to combat skill decay and work towards mastery of skills. And this is the type of mastery of competency graph that we want to see. You want to see that straight line. Better delivery of high-quality CPR to our patients will definitely save more lives. On successful completion of RQI activities, a virtual course completion card will be issued. This simplifies card management, it's definitely eco-friendly, and it's convenient. Providers have self-access to card replacement, and they can print it if needed. So no one has to run to the training center coordinator when they have lost or misplaced their cards. They have full access to everything that they need. On the completion, both a standard 2-year AHA card, if needed for regulatory requirements, gets issued, and the gold standard, as what we see here on the screen, the RQI verified card gets issued. Here is a sample of my BLS, PALS, and ALS card. With RQI One-Stop Management Platform, it provides us with automated RQI scheduling and assignments. The system has integrated notifications to participants, and our administrators can customize these notifications. The administrators also have easy access to reporting of student participation, and RQI Analytics that Josh has mentioned also provides us with excellent information about where our organization stands at any given time with the quality of CPR that our team performs. With RQI, to quote Lynn Ann Walden at Seton Healthcare, for us, it hits the trifecta. We found that the program is innovative, it's creative, and it ensures quality improvement, which leads to better patient outcomes. It provides convenience to our team as staff members can access the stations when they are ready, and it also helps with cost savings. High quality CPR saves lives. We need to understand where we can change in our program to increase survival rates. Organizations that are committed to high quality CPR training deliver high quality for every patient, every time, regardless of outcome. Lastly, to close this presentation, I want to quote legendary American football coach Vince Lombardi. Practice does not make perfect. Only perfect practice makes perfect. Thank you.
Thank you, Mr. Marius, for the comprehensive presentation. We'll move now to our last speaker, Dr. Hatem.
Okay, first, thank you very much, Mr. Khalid and Mr. Rami, for inviting me for this very interesting webinar. And actually, I want to join you in a journey of resuscitation into Saud al-Batin Cardiac Center. First, I want to discuss with you why we need an RQI. We have a well-established classroom-based ACLS, BLS, and pulse. With most of our people who satisfied with the classroom. So why we are shifting from the classroom-based to RQI? First, we know some facts. I will share it with you. That in hospital cardiac arrest present a new critical challenge in which healthcare provider performance quality can significantly alter patient survival rate. In hospital cardiac arrest, we have a low frequency in most of the hospital. It's about 4 per 1,000 admission. So most of our staff will not need cardiac arrest every day. So we need to have a good training program in order to keep our people sharp and ready at any time. As Mr. Marius said for us that we have only 25% survive from cardiac arrest. So there is window for improvement of our performance. And significantly, there is variation between different hospitals in the outcome. We find that in 10-year survey in the United States, they have 42 variation from hospital to hospital. Some hospital has up to 40%, and some people have up to 5%. So when we try to know what is the reason, can you shift next, please? So when they are trying to find the reason why there is variation between the hospitals, they found the most important cause is inconsistency of CPR quality. And it is our responsibility as a hospital to find a solution for our problem and why we have a bad outcome. We know that delivery of poor quality CPR is considered a preventable harm. And the high dose, low frequency training dose not sustain provider CPR competence and skill, as Mr. Marius said, will decrease gradually from 0 to 12 months until we reach a very low standard. Next. 4 years ago, we changed our QBI for cardiac arrest from the patient of return of spontaneous circulation to the patient who's coming out of the hospital with brain intact. And we found that these QBI are more reasonable than other QBIs. And when we try to find that benchmarking our result with the other, we find that we are a little bit behind some of the hospitals, especially in the United States and United Kingdom. So we try to find a solution to improve our quality improving our quality in the CPR. So as we all know that the brain will start to be affected after 4 to 6 minutes of cardiac arrest. And the early and effective CPR keep blood flowing and provide oxygen to brain, other vital organs, giving the victim a better chance to full recovery. And this is our target. If CPR is given within the first 2 minutes of cardiac arrest, the chance of survival will be doubled. So the scientific evidence have demonstrated that survival from cardiac arrest is dependent on the quality of the CPR and strict adherence to recent guidelines. Next, please. It's not telling me. Okay, so when the CBR committee in our hospital we have a meeting and we try to improve the outcome, especially after we revise our QBI about the outcome and good neurologically intact patient. And we are depending on improving 5 goals. First is how to improve the timing for responding to CBR. And this is done by improving the communication and dedicated team and the fast response and how the team is going to respond to cardiac arrest. Second, we depend on improving the skills and the competency of most of our staff, and also improving the knowledge and improving the teamwork and delivering high quality CBR. Next, please. So in 2015, the AHA have launching the RQI program to address the urgent need to improve hospital cardiac arrest survival through a novel competency-based model for healthcare providers. The 3 modalities, the BLS, SLS, and pulse training model, by providing self-directed, low-dose, high-frequency CBR skill activity with the objective of skill mastery and retention, and this will achieve our goal, which one of the 5 goals I mentioned before. Next. So what is the target from improving of our skills with RQI? First is the RQI compression score, which is depending on the rate, the depth, chest recoil, and the CCF and the correct hand position. All these have been monitored by the RQI. The other target goal is the ventilation score, which is the volume and the rate and the compression ventilation scale evaluation. So this is the most important 2 items or 2 things we want to achieve to reach a successful CBR for any patient. Thank you. Next. So in 2018, we started to be the first center in Saudi Arabia to apply the RQI in their resuscitation or CBR quality improvement program. And next, please. And then after 6 months, we started the first training program in Saudi Arabia. And this is the first team that we are sharing with it, that they are the team that we are formulated for working with RQI. We have 2 machines. One is mobile from different area in the hospital, and the other one is fixed to a specific place, so the people will be convenient and we reach the people where they work instead of coming to us. Next, please. Next. So after we implemented the program for 2 years, now it's time to ask, did it really help us, or we have to go back to classroom-based workshop, or what we do? So we are depending in 2 main factors. One of them is we done multiple survey between our staff to know their satisfaction. Did they improve their skill? Did they improve their knowledge? And the second thing is by CBR committee to observe and record and monitor the performance of our staff. So in this survey, we are asking the people, are you think your skill and knowledge are improved? Are the CBR psychomotor competence and confidence improved? Are you satisfied and efficient or sustainable while you are using the RQI? And then we ask him about, what about the team dynamic? Do you think you are improved when you work in a team or not? And we open for suggestion from different category of doctor, nurses, and to know what is their suggestion. Next, please. So we are enrolled 81 person, and we divided them randomly between physician, nursing, and technician. Of course, nursing was the highest part because they are the highest in our center. And also physician, we choose consultant, registrar, and resident, and we also ask a technician. Next. So this is survey results. We ask him about the is the instruction during the skill practice session was clear from the mannequin, and most of them was strongly agreed or agreed. And second question, did they provide you with accurate assessment of chest compression quality and ventilation? Most of them agree or strongly agree. Third question is the quality and tone of the voice was clear and well understood. They are happy to work with mannequin more than they work in the classroom. Most of them agree or strongly agree. And the last question we asked, this was from the infection control, because this is using from multiple people. Are they satisfied from our infection control and clean mannequin? And most of them agree or strongly agree. Next, please. But what was the major disadvantage of the comment of these 81 people? Most of them have said that they decrease the efficiency in working team dynamics. And when we ask him about what you mean by team dynamic, they mention closed loop communication, knowledge sharing, how they're going to switch between the compressors, and how they do constructive intervention. They miss this in the classroom. We try to solve this one problem because this was also mentioned in survey we done 1 year before by doing drills in different areas of the hospital, by doing mock for all the people in different areas of the hospital. But in spite of this, the people are still thinking that they need to improve the RQI by finding how can you do a drill and to be part of their training. But the most advantage, and they mention it, that during the pandemic of COVID-19, we did not stop our training program. We stopped the classroom-based program, but we did not stop the RQI. And they find that is a major advantage, especially we receive a lot of new staff during this time, and we are able to continue educating our people about CPR. Next, please. Another problem was facing as a head of the CPR committee that we are working in a cardiac center, and we have frequently facing the patient of cardiac arrest in the cath lab during PCI, and we have a problem of continue giving CPR while the intervention want to open the coronary artery in order to resuscitate of spontaneous circulation. Also, we are frequently during CPR, we are inserting ECMO, we are sending intra-aortic balloon pumps, and we want to do a PCI. Also, it was a problem in doing CPR. Other problem is during transportation of the patient from the ER to the cath lab, and we want to continue doing a CPR, and this was not achievable. And actually, we solved this problem by implementing a new machine which called the Lucas 3, third generation in our CPR committee. And actually, it solved most of our problem by it's provide a uniform, effective, high quality CPR. It provides consistent and not interrupting chest compression, and we are able to do all the invasive maneuver with patient continuous CPR and transportation of the patient from area to area. I won't just share it with you this slide because I think that is a much improvement of our quality of CPR and significantly improve our outcome. Second thing, after we asked our staff about what is their impression in the RQI program, we have to monitor our performance and we have to monitor, are we in the right track or not? That's why we want a third party to observe and to monitor our performance and trying to give us feedback about our performance. And that's why we need to make with AHA a cooperation which we enter into get with the guideline resuscitation RQI program. So in our center, the CPR knowledge and skill, competency, and clinical quality improvement helped our staff to confidently respond to any cardiac arrest event on time. Next, please. So what is the GET with a guideline program? GET was a guideline program that all our patients with cardiac arrest, we have a form, which is CPR form. All this data was uploaded to the system of the GET was a guideline. And the people in the United States, they are doing us the teamwork, they're revising all our data, all our performance, patient by patient, and statistically, they benchmark our result with different hospitals internally and externally. And we're trying to solve the problem with that and improve the quality of our mistake. And actually, they discover some weak points in our performance and our system, and we working in with them in a team in order to get a better outcome, which I will going to show you on the next slide. Next, please. So what is the resuscitation event that being tracked with the GET with the guideline? We have 3 resuscitation events, which rapid response team, acute respiratory compromise, and cardiopulmonary resuscitation team performance. So they are monitored every resuscitation event or activity in our hospital. Next, please. So what is our journey with this GET with the guideline project? There is certain measures are being monitored aiming to improve outcome during our in-hospital cardiac arrest. Event to be monitored and witnessed. So if we want to see how many patients have been arrested unwitnessed or unmonitored. And they put a target for us that the time of the first shock should be less than 2 minutes for VF or pulseless VTAC. And also they give us a target of patient who received epinephrine and a systole of pulse electric activity of less than 5 minutes. And they want to see what is the percentage of the patient that had been confirmed endotracheal intubation with a wave capnography. So this is the first 4 targets put it for us with GET with the guideline to monitor and improve. And let's see what next, please. So this is the report we received from GET with the guideline group in AHA. And they monitor that the time for first shock less than 2 minutes for VF or pulses VTAC was about 96.2% for 2021. And time for IV epinephrine in the patient receiving less than 5 minutes was only 90%. But the patient who are not monitored and the patient who have present pulseless cardiac events monitored or unwitnessed, the patient was witnessed in 100%. There is no one patient missing. And actually this is because we are using telemetry for most of our patients who was unstable in the hospital. And confirmation of airway device placement in trachea, we reach about 99.3%. So this is a report from the GET with the guideline 2021. So this is a comparison of patients who are the performance in 2021 and 2020. Can you push next, please, Mr. Ram? Stop. Okay, so this is a 2020 and this is a 2021. And here we are monitoring the time for first shock, and we was target less than 2 minutes. And we reach in 2020 about 88%, and we are improved in 2021 with 96% by just monitoring and the cooperation of GET with the guideline group and just putting an action plan to improve our performance. And as you see, we have a significant improvement in our performance. Next, please. The second parameter was monitored with the people with the GET with the guideline is the using of epinephrine in less than 5 minutes for the patient with pulseless electrical activity or asystole. And it was in 2020 about 84%. It needs to 87%. Next, please. The third parameter who is monitoring is the patient of the percentage of patients who are not witnessed the cardiac arrest in 2020, we have most of them was 100% and 100% 20 and 2021. Compared to 2019, we have missed about 4%. So we are improving also, and we have benchmarking with United States. Confirmation of airway placement, we posted them in 2020 and 2021. We reached 100%, and this actually was much improved from 2019, which about 50% until we implement the wave capnography in all area in our hospital. Next, please. So as you see that we are in all our data was uploaded to the Get With The Guideline group, and we have frequent meeting with them every 2 or 3 months or as we need it. And they are just taking our data, they analyzing, and they benchmark it with our different hospital, and they give an action plan to improve our performance. So once we started our program, we were enhanced to provide additional resources, tool, and benefit, which include excellent staff performance and professional education opportunities and continuous quality improvement by getting easy access to most up-to-date research on RQI, which provided with Get With The Guideline group. So what is our future perspective as a CPR committee? We are willing to serve as advocate to other hospitals in case, say, you know now that Saud Al-Battin Cardiac Center become in a big group, which is 12 hospitals, which called the Cluster 1. And this, we are trying to spread our experience or our working with the American Heart Association in Get With The Guideline resuscitation program to most of these hospitals. We also implement Get With The Guideline heart failure program in Saud Al-Battin Cardiac Center, and they're doing excellent performance, and they get, I think, the silver reward. And also we're trying to spread the RQI to most of our cluster in different hospitals into our cluster. Next. Oh, thank you very much for you sharing with me this lecture. Thank you.
Thank you, Dr. Hatem. Thank you. We appreciate all the information that you have shared. Thank you. So we'll go to some questions from the attendees, if you don't mind. And thank you, Josh, for answering some of them. So we'll start, let's say, with the first one. I know you have answered it, Josh, but for all the attendees to know that about, is there any criteria for the hospitals that would be participating in the RQI? So if you please highlight this for the all our guests today.
Oh, so the question related to the requirements at the hospital, Rami?
Yeah, exactly.
So there's not requirements specific other than hospitals who have participants, who have staff who are required to maintain their BLS, ACLS, or PALS are all perfect places for RQI to be implemented at.
Thank you. What about the life support instructors to maintain their skills and renew their cards as well?
Yeah, so that's a very common question that we get almost every time we talk about RQI, and it's and I see Marius smiling because I'm sure he's had to answer it 1,000 times. But it's, RQI is really it's a quality improvement initiative for the organization, and they're taking a stance to drive the resuscitation quality in their organization. And then when they do that, this really provides an opportunity for the staff who may have helped previously as instructors to kind of shift their focus a little bit and through doing activities like participate as super users and help learners. They can, we see a lot of hospitals who utilize instructors for things like helping with their mock code program. And, we highly encourage that there are activities that take place around to complement RQI, like team training, communication, practicing communication skills and things like that, that are specific to your organization, so that you can run your mock codes or run your drills, and you don't have to focus on the things like high quality CPR, because your providers are maintaining that when they do their RQI. So you can really focus on the other activities that will contribute to the success of a cardiac arrest event in your organization. And sometimes that's different. Those are different things depending on where the cardiac arrest may happen.
Thank you, Josh. Thank you. Other question maybe for Mr. Marius. People enrolled with RQI for ACLS and Pulse raised a question or a query how the core case scenario accomplished through the RQI.
So the foundation of the RQI system is obviously your BLS component. That's the number one key factor. And that's the first thing that's been proven to save lives. Now, how we have implemented the PALS and ACLS, so they get allocated a program which is still online. They do the cognitive work. They complete all the formalities. It takes a couple of hours. It's similar to what some people are familiar with as the hard code. And then from there, how we implement these team dynamics, the skills, the practice. We basically have like mock drills, skill drills that we're running. And I've mentioned in my presentation, we actually do it monthly in all of the departments to make sure that staff are constantly practicing these skills, because sometimes there is a concern. They just do it on the RQI and it's finished, but it's not like that. We have to make sure that the staff is practicing as teams. They learn how to communicate, how to use the specific equipments that they have available in their hospitals, and that they know how to use the equipment. And that's how we have handled the integration of the RQI, ACLS, and PALS. But it's possible, but it takes some work.
Thank you, Marius. Another question similar to Dr. Hatem, maybe this time can answer it for us. So is the RQI is specific only for BLS, and what about ACLS and Pulse? And if you can share some experience as well from your side, Dr. Hatem, how you are doing with that at your hospital, since we have you in Saudi Arabia and Marius in UAE, so it would be good to share best practices.
Well, actually, we have the three category in Saudi Al-Waqtin. We have BLS, we have Pulse, and we have ACLS. And I share with Mr. Marius the same concern that it's good that we have excellent psychomotor skills in CPR and ventilation, but still that without making a drill, you have a significantly reduce in the people working as a team. We observe when we start RQ first without doing drills or mock, that we find that the people, when you are going to see them in the real life, they are not working as a good team. For example, changing the compressors. You find that a lag between changing compressor, and you can never reach the CCF of 80%. So you have to go to the people in their places, and you have to give them a mock drills, and you have to do it frequently. I know that sometimes people have departments that tell you that it is not convenient. We have work to do in the cast lab. You are interfering. You have to negotiate with them. But by the end, we have support of our CO that it has to be done. And that's why we have a successful program in our hospital.
Thank you, Dr. Hatem. Thank you. I'm not seeing any other questions. So let me see here. Maybe there is another question. Maybe Josh will go back to you here. Are the institutions that just implement BLS and then continue conventionally training advanced support for advanced life support classes? I believe it's the same question, so only the BLS, no, we can implement all the courses, BLS and ACLS, and the same question that has been answered by Marius and Dr. Hatem. Okay.
Yeah, the one thing to point out though, when it comes to RQI, ALS and PALS is when you bundle all of the RQI courses together, you not only have your skills are done in your BLS course, because that's the foundation of ACLS and PALS. And then if you do ACLS and PALS as RQI, they become it's just their quarterly e-learning add-ons to be done on a quarterly basis that are associated with your ACLS algorithms and your PALS algorithms that ensure that the learner has knowledge about those algorithms and walk the learners through knowledge checks for each step of the algorithm.
Maybe last question, which is addressed directly to Mr. Marius. Did you run any study for the impact of the RQI on the quality of CPR delivered by staff in the hospital?
At this moment, we are running quality improvements. So after every code that we have, something similar that Dr. Hatem is doing, we have a QI form that we completed. We are looking at areas of improvement and things. At this moment, we are not enrolled in Get With The Guidelines, but we are planning to enroll with the Resuscitation on Get With The Guidelines as well, so that we can have clear data that's being validated by an international organization like the AHA. So yes, we are monitoring, but international data, benchmarks, best marks, we don't have at this moment.
Thank you. I believe we will take only one more question, and then we'll come back to all the other questions later on, since we exceed the time. So there's a question for you, Josh. As we know, RQI is a quality improvement program. How do we differentiate which level of expertise and learners require for a new nurse or with someone who is expert, if we want to say?
Yeah, that's a very good question, and there's different approaches that different hospitals take. So it depends often on whether or not the learner has any past experience with BLS. If they've never had BLS, you would want to make sure that they get that foundational knowledge, and then as far as they'll get all the required learning through the prep course. The other approach that we see many organizations take is that when they start RQI, all learners start with the prep course, and they do that because it's an adaptive program. So if the learners do indeed have that foundation of knowledge, and what they do is then they are able to much more rapidly complete the entire program, and the same program will then provide a novice learner or a beginner with the content that's needed to establish that foundation of knowledge. So it kind of is up to it depends organization to organization. We have lots of examples of best practices that we can share, and ways that learners are doing it.
Thank you, Josh. Last question. This is the last, I promise.
Yeah, no
for
problem.
Khaled. So Khaled, can you provide information for hospitals who are interested in doing the RQI and the Get With The Guideline resuscitation, and what is the next step, how we can assist them from our side?
Yeah, thank you very much, Rami. Yes, sure, definitely. We will identify all the people who attend today, and we'll be sending to you more information about the program with our emails, addresses, and we are more than happy to schedule one-to-one meeting with each one interested, and depends on the facility, and provide all the needed support in order to implement it successfully at your facility, definitely.
Thank you, Khaled. Thank you, our speaker, and thank you, our attendees for today. And we appreciate your commitment. We will respond to your questions if we didn't answer it, and we'll be sharing more information. Just before we leave, there is an evaluation to be completed. But before the evaluation, if there is any final word from our speakers, Josh, Dr. Hatem, Marius.
Just thank you very much for the opportunity to share information about our RQI, and it's always a pleasure to work with you guys, Rami and Khaled, and great to see you, Marius and Dr. Hatem. So yeah, please reach out to to these resources, and any of us if you have any questions.
Thank you very much. Thank you, Josh.
Marius, Dr. Hatem.
Thank you
Thank you
all.
very much.
Thank you.
Thank you. So,
So
we have three
we'll
groups.
take-
The first one is done, webinar management. Then we'll be asking you another one, which is about the material you have we have presented today. Kindly answer again 3 questions.
finish Khaled.
Yes. Okay. Perfect. And the last one about our amazing speaker for today. I believe we are good now. Thank you very
Okay.
much. Done. Yeah. Thanks.
Thank you, Khaled. Thank you. So really, we appreciate your effort. Thank you for our speakers. Thank you for our attendees for today. And before we leave, we want to wish you a Ramadan Mubarak and تقبل الله منا ومنكم صالح الأعمال. And have a good rest of your evening. Thank you.
Thank you very much. Thank you.
Thank you.